Hello, and welcome to this episode of A Cancer Conversation with the Georgia Cancer Center at the Medical College of Georgia. I am your host, Chris Curry, and in this episode, we are going to be talking about leptomeningeal disease, what it is, what treatment options are available, and why a new clinic at the Georgia Cancer Center was created to offer patients an individualized treatment plan. Joining me for this conversation is Dr. Gerald Wallace. Dr. Wallace is an assistant professor of medicine in the Department of Hematology Oncology at the Medical College of Georgia. He is a neuro-oncologist working at the Cancer Center and you created the leptomeningeal disease clinic here.
That's right, yeah.
Dr. Wallace, thank you for joining me for today's discussion.
My pleasure. Thanks for having me, Chris.
Now, before we talk about what leptomeningeal disease is, I want to talk a little bit about you. Why did you choose a career in medicine and cancer specifically?
Yeah, so the first part of that question is a relatively long answer, and I'll try to shorten it. The reason is what I first remember being interested about in medicine was when my mom was pregnant with my little brother. There was a book that came out in the 80s, had all these photographs of developing human fetus, and it was just beautiful. And so I got to, see what he looked like at every month or every week, wherever we were. And that got me really interested as a young kid. As I got older, the story really shifted more towards cancer when my grandparents passed. So 3 out of 4 of them had cancer or some sort of precancerous conditions. My dad's had cancer. And as a neurologist, everyone has had some form of impactful disease related to neurology. So that really drove me. My dad's mom died from lung cancer that had metastasized to her brain. His father, my namesake, Gerald Jr., died from complications of Parkinson's disease. And then my mom's parents, her mother died from multiple myeloma, which and she passed at a time before bone marrow transplants were commonly available. If she'd had that disease today, she would have been transplanted, even at our institution. It might have lived another 10, 15 years.
Yeah.
And then my grandfather, my mom's father, probably the smartest guy I've ever met, was an engineer, used to work for Westinghouse, and slowly died from vascular dementia related to polycythemia vera, and then eventually passed from a brain hemorrhage. So kind of neuro and cancer have been deeply in my life for as long as I can remember.
Yeah. What does it mean for you now, having that experience, bringing sort of your experience, your personal experiences into your professional world, and being there for patients who are diagnosed with brain cancer, because that's your area of expertise?
Sure. Yeah, so we see all the advertisements on TV, and even in med school you get trained. The worst day of life is when you hear the big C, cancer, as your diagnosis. I would argue that the only thing worse than that is seeing me as your new doctor, because it means you have something in the brain and it is cancerous. Or it is cancer adjacent, which is actually part of my job. So I approach every patient visit as the worst day of their lives for a new patient visit, and have to go in with the conscious thought that they can't say anything wrong on the first encounter because they need my help. My job is also very palliative at times, so we have a long way to go to improve survival for patients with brain cancer or metastatic cancer to the brain. There have been some huge strides in the last 5 years alone, but there's a lot left to do, and that's part of the reason why I think it's important to see these people and talk to them in a cancer center at an academic institution, because we also need to get them excited about getting into trials and doing things with us that maybe aren't standard of care yet, but we're hoping to push that bar forward. The last thing I'll say to that is it's really important, I think, also to keep family involved. No one can go through this alone, and in fact, one of the hardest group of patients to treat are those who don't have people nearby. And we, in Augusta, unlike in Atlanta, have a very large region that we cover in South Georgia and parts of western South Carolina. And it can be logistically impossible for people to get treatment without resources to help them. And so that's also a big part of our conversation and what we do.
And what was it like in medical school for you? Because I know I've talked to people before that were sort of like, I got into medical school and I tried this and I tried that, but it sounds like you pretty much knew your path.
Yeah. So I do have a background in science, and the first thing you do is you come up with a hypothesis, so you make a prediction. I predicted I wanted to do cancer, and then I did everything I could to disprove that, I feel like.
And here you are today.
Yeah, here I am. No, I failed miserably, and now I'm a neurooncologist. No, it was it was on my mind. I'd met some people, had the experiences that kind of drive you to the ultimate conclusion of this is what I want to do with the rest of my life. Medicine, we always joke in intern year, or in really your first or second med school year, of do you want to cut or not? That's your first question. And then after that, it's sort of what gets you excited to wake up in the morning. And despite, what you might say is a depressing career choice, I love doing this job. Everything about it is just fascinating to me.
How so?
We don't have all the answers. It's really fun to go in somewhere and not know what the answer is. I maybe shouldn't say that as a physician, but that's really one of the most exciting parts.
So that's really the growing, you talk about the huge strides in the bone marrow transplants. I mean, medicine, not just the technology that we use, but also the different treatment options are always changing and growing and evolving.
Right. Yeah, I remember in college, we did I was in a lab working with one of my biology professors, and she showed us something and said, when you started in 2000, 2001, I forget what year it was exactly, but she said, at that time, every year on PubMed, the sum total of all biological papers doubled yearly. Another way to interpret that might be to say the sum total of human knowledge in biology doubled yearly. It's not just 1 million papers this year, 2 million last year. It's 1 million papers have ever been written, 2 million were written this year. Mm-hmm. By the time I graduated, that doubling was every 6 months.
Oh, wow.
At 2023, God only knows, and that's just English language journals.
Yeah.
I mean, there's an entire 2 to 3 billion people whose voices are not English, and they're starting to produce some really high quality science. Not there yet, but it's getting there. And it's kind of daunting, to think of all the new things that we'll discover and all the things that we don't even know to ask about right now.
Yeah. So working as a neuro-oncologist, you specialize in cancers of the brain and
Mm-hmm.
spinal cord, but I had never heard of leptomeningeal disease until you mentioned it to me. So what is it?
Yeah, it's a good question. Leptomeningeal disease is really referring to sort of a type of metastatic cancer. And the leptomeninges are 2 layers of tissue that cover the brain and kind of support it. Everyone knows you have a brain, everyone knows you have a skull, everyone knows you got fluid around the brain that keeps it protected, and the leptomeninges are the innermost layers that kind of support the brain. It includes the surface of the brain, it includes the blood vessels around the brain, and it includes the fluid that is in that space. And it's a pretty daunting space for cancer to survive in. It's kind of not meant for anything to live there. In fact, it's very hard to live in that fluid. When cancer gets there, it's incredibly serious and life-threatening. Even if, people come into my clinic, they look like you and me, totally normal. At least I presume you're normal.
I try.
No medical issue, or maybe they have medical issues, but they're kind of dealing with everything just fine. And then I look at them and say, hey, the cancer's in this fluid, and if we don't do something, you've only got 6 weeks. And it's really terrifying.
Yeah, that's not a long time at all.
No. But it is a disease that has actually been studied for at least the last 50 years. And we've known that it's present. We know that cancer can get into this space. And we know that 5 to 8% of people with cancer will develop leptomeningeal disease. Now, whether that's the cause of their death or if something else is happening, we don't know for sure. But that's based on 50 years of data, and actually a paper that came out in 1998 told us that. And really, in the last 20 years, we've been able to do something meaningful about it.
Do we know how it gets into that space, into that fluid?
That's an excellent question. If you can figure that out, you'll make $1 million today.
Okay.
You'll be a billionaire. It's one of the big questions. We know roughly how it gets there. You know how a car goes from point A to point B. Why it's able to refuel at point B depends on a lot of things.
Okay.
I'll stop there. It's a very complicated answer
Okay.
to that question.
Gotcha.
Yeah.
Is it only in brain cancer patients, or can a breast cancer patient have a metastasis, which means it moves to another area that ends up as leptomeningeal disease?
That's a good question. So yes is the shortest answer. In fact, it's more common in patients who have cancer outside of the brain to develop leptomeningeal disease.
Okay.
Probably the most common cancer that gets into the leptomeningeal space is leukemia and sometimes lymphoma. Those are actually quite treatable. But among the patients who have, as we say, solid tumors, that's where the shortest lifespan and the shortest overall survival are. And it can be a really rapid progression. So we have to find ways to move quickly and deal with that.
So you started that clinical program here to see patients with this disease, with leptomeningeal disease, which we believe to be the first in all of Georgia as of this recording, which is June 2023. Why did you feel that this clinic was necessary and needed? You talked about, the short lifespan and taking action right away.
Yeah. So there are maybe 10 names total in the world that have been really working in this space aggressively and with great purpose and great success. One of those people is a fellow by the name of Peter Forsyth, who was my mentor at Moffitt Cancer Center in Tampa, Florida. That's where I trained for my neuro-oncology fellowship. And while I was there, we did a retrospective review, just trying to see, what are the cases of leptomeningeal disease that we're seeing, and what are their outcomes? How well are we treating them in this place? And what was fascinating was he came sometime shortly after 2010, I think like 2013 or something, to Moffitt. In 2010, they had identified 2 patients with leptomeningeal disease in that first year. And then by 2021, which was the last data point I had, they had found 28 patients.
Okay.
And so the concept, and that's just for breast cancer, that doesn't include all comers. It's actually probably in the hundreds a year, depending on how many patients you see. The point was, if you're not looking for it, you're not treating it. And if you're not treating it, people are dying. And you're saying, well, they're just passing away from their cancer. And I mentioned that 6 months was a survival timeline. That's true, or 6 weeks rather. 6 weeks is definitely what data has shown consistently year over year for 50 years. This is how long you live with leptomeningeal disease. But if you treat it, it can be years. That's optimistic. Most people will get about 6 to 12 months, but 6 to 12 months is the next graduation. It's the next wedding. It's the next birth of a kid. And at the end of the day, I think we're all just fighting for time to spend with our loved ones anyway. So we should do something. And treatment's not that bad. It's actually quite tolerable.
So what does it mean to you so we talked a little bit about working with the patients. Have you had any instances where that has happened with you, where you've been able to treat someone to give them more time so they can make lasting memories like weddings and graduations and things?
Yeah, so that's a great question. So in November, the first patient I signed up for the clinic had non-small cell lung cancer, and she got a surveillance scan. She had brain metastasis prior to November, and they were just getting an MRI to make sure that was all cleared up, and lo and behold, she's got characteristic signs of leptomeningeal disease, and we confirmed that diagnosis and then started her on treatment. And I'm happy to say 7 months in, she's doing quite well. In fact, Usually in a cancer clinic, you get nervous when a patient misses an appointment, but I'm pretty sure she missed her appointment last week because she was out doing something more fun.
Nice. More fun than coming to see you.
Yeah, well, I hope there's a lot more fun than coming to see me.
So you talk about, people appearing normal, but finding it on the scan. What are some of those signs or symptoms or things to look for, or is there nothing to look for and it's just those follow-up scans?
Yeah, no, the symptoms can be kind of anything. The stuff that really gets someone like me nervous is when someone comes in and they have neuropathies, so specific nerves that aren't working right. And as a neurologist, our first job is to figure out where that is. Mm-hmm. And if you have, say, problems with the nerves that are involved in facial movement, taste, opening and closing your jaw, speaking, swallowing, eye movements, all those things, if you've got problems in one nerve here and one nerve over there and I can't connect the two, that really makes me nervous that something's going on kind of in a more global space than would otherwise be indicated by, say, a tumor that was sitting in the visual cortex and you can't see well. The other signs or symptoms, rather, that are perhaps more obvious to a patient is signs of increased intracranial pressure. And this can be very mild. It can be just a headache and a stiff neck. But with that, maybe they're having a little trouble walking. Their gait gets a little more shuffly and difficult to go. Their headache is worse when they lie down, which would go with a high pressure in the skull. And maybe they've had some urinary incontinence or even, God help them, some bowel incontinence. And that can happen a lot in cancer for other reasons. But when I hear those things all together, and maybe a little memory impairment or something, those three things together, the memory impairment, the gait problem, and the incontinence can all go together for high pressure in the brain. And that frequently is a presenting symptom of leptomeningeal disease. I think the reason that gets missed a lot of times is these patients have had cancer most of the time for quite a while, sometimes years. And so you get used to saying, oh, they've been through a lot of chemo, or they're just tired, they've lost a lot of weight, there's a lot of this, there's that, they've got an infection. Just leave them alone, let them be. Don't hurt them anymore. To which I say, don't do that, because
you can miss.
I can fix it if
Yes.
we can do that. Sometimes it's as simple as just doing a lumbar puncture. You relieve that pressure, and suddenly they walk. They can go to the bathroom again or control themselves again. They can talk and remember things. The headache's gone. And then we start the easy process, which is just treating the cancer that's there.
Talk about how important honesty is between you and your patients, and trust is, because
Oh, man.
whether it's been missed or whether you decide to dive deeper, like, it sounds to me like honesty and trust between you and your patients is paramount.
That's probably true. Yeah, I think so. I try to be as upbeat as possible, mostly because I know that my clinic is not one you want to find yourself in. But the other reason I try to do that is to get people to feel comfortable. Sometimes that means tolerating things, language that I don't particularly like, but it's okay. It's fine. They've got brain cancer after all. What am I going to say?
Yeah.
But I think if I am honest with them and they're honest with me, then we can actually do something. And the funny thing, I guess it's not funny, but probably one of the most beautiful things about having a diagnosis of cancer is most people stop fooling around. They stop lying to themselves. They stop lying to other people. They stop hiding things because A, doesn't matter anymore, and B, they don't care anymore. And yeah, it makes for some abrasive conversations at times, but that just makes life more fun.
Yeah.
I think that's the way to go. So I think it's valuable. And if they don't tell me what's going wrong, then I don't know to fix it.
Yeah.
But I don't think I've run into people who haven't been honest with me. No one's hidden something yet. And that's
good.
Yeah, I think it's great. Yeah.
So talk about those treatment options if someone is diagnosed with leptomeningeal disease.
Sure. So first things first, we got to diagnose it. You got to be certain because the treatments aren't always benign. I say that they're not that bad, and they aren't in the context of the disease. But step one is radiation. Ideally, the radiation would be to all the places where the cerebrospinal fluid goes. So that would be the brain and the spine. We don't like to do traditional photon beam radiation to the spine. It comes with a lot of bad side effects. But you can get proton beam radiation. We don't have that facility here, but they have it in Emory, and then I think there are fewer than 15 places in the country that have proton radiation. But that's also an excellent option. In lieu of that, you can just do whole brain radiation. Side effects of all these things are mostly fatigue. You may have a little bit of neuropathy, maybe some vision changes, memory impairment, but we can mitigate a lot of that. So that's step one, and obviously I don't want to do that to somebody unless I know for sure. Mm-hmm. So we see the MRI, we have the suspicion, or we have the clinical exam, and we're suspicious. The next thing we'll do is we'll jump to a lumbar puncture, which is, most women are more familiar with this than men if they've had an epidural during delivery of a child. It's very similar to that. We just go one layer deeper. And then we take a little fluid sample and we analyze it and see if there's signs of cancer cells in that sample. We got to do that twice.
Okay.
If the first lumbar puncture is negative, there's still a 50-50 shot that it's a false negative. So we need to do it again.
Okay.
However, if you have an MRI that's highly suspicious for leptomeningeal disease, sometimes we'll defer that if it just kind of has a knock it out of the ballpark picture for the case and if the patient's clinical exam matches it. Once we do that, we talk about radiation. Once radiation is done, we sign them up with one of our neurosurgeons to get a special device called an Ommaya reservoir. And, a lot of people are familiar with the idea of a port, which is sort of a way to access easy way to give people chemotherapy without having to do sticks in the hand or in the arm. You get a special device installed in the chest, and then you can just give chemo that way and take blood samples. An Ommaya reservoir is the same thing, same concept, but this time, instead of the access going into a blood vessel, it's going into the cerebrospinal fluid in the brain. And it sits usually under the hairline, because we like to think that the hair grows back after everything we've done.
Yes.
And it's just a little bubble on the scalp, and it's a way for me to test spinal fluid. It's a way to relieve pressure for patients who have increased intracranial pressure, and it's a way to deliver chemotherapy, which is the final phase of treatment. And what we do is here I use a drug called topotecan as sort of my catch-all. If patients have a cancer that has a specific mutation, then I'll get a tailored medication that fits with that, and we work with their primary medical oncologist to figure that out. And then they get treatments weekly for a couple of months, and as they improve, we back off and go every other week, and if that improves, then we go to monthly. And then, I haven't gone this long yet, but I have seen cases down at Moffitt where we sort of just take a break and see how things go. Occasionally you get somebody who's gone a year or two since a diagnosis, and that's the goal. The last thing is to make sure in collaboration with the other clinicians here, for metastatic cancer, like breast cancer per se, I want to make sure I work with the person who's been taking care of them before me, because I'm not the guy to treat your breast cancer or your liver cancer or your lung cancer.
Yeah.
There is a role for systemic therapy, and this year at ASCO, there was a huge, that's the American Society for Clinical Oncology, up in Chicago. They had some huge breakout drugs that are really exciting and potentially also useful for brain metastasis. And if they're good for brain mets, they're probably good for leptomeningeal disease. We just have to push those trials. A little off topic, but that's really the last reason that I have the leptomeningeal disease clinic, because we can't do a trial until we know where the disease is and who's got it. And I think there is great potential to make big strides in survival and quality of life for patients with leptomeningeal disease.
Are there some cancers that are more prone to leading to leptomeningeal disease than others? You've talked a little bit about breast cancer and...
Yeah, that's a good question. So the top three are lung cancer, breast cancer, and melanoma. For women, I would say that breast cancer is going to be the number one cause in the coming years as people stop smoking and stop vaping, which, by the way, is also not healthy. But for men, it'll probably be lung cancer and melanoma. Those are going to be the top two. Roughly 8% of patients with lung cancer may eventually develop leptomeningeal disease. That has to do, it's probably 8 to 12% over the lifetime. It depends on which article you read. That has a lot to do with people living longer with lung cancer and just having that potential for that occurrence.
Yeah.
Melanoma is similar, slightly less, probably around 5 to 10%, and then breast cancer is 5 to 8. But like I said, that 5 to 8, when more people have breast cancer than lung cancer, that's going to be your number one contributor. And then we're in the South, so melanoma. Melanoma for all. Don't wear flip-flops. That's my summary for that.
Gotcha. What are some common questions that you hear from your patients, and how do you respond?
Yeah. It's funny. I always figured in med school that the question would be, Doc, how long have I got? No one likes to ask that question.
Yeah.
And I suppose I wouldn't like to ask it either. But that's definitely in the top 5. Okay. Eventually you say, what can I expect?
Let's talk about that. Before you go on, let's talk about that, because you talk about mutations, like cancer care and treatment is becoming so individualized these days that you can't use a I feel like you probably don't want to use a blanket statement of how long do you have, because everybody is different and people react differently, right?
Yeah, no, that's actually an excellent observation. It's when so all the HEMONC fellows, I tell them this, is like, I don't actually care where the cancer came from. It's in the brain. At that point, what I care about is to remark on your earlier question, how does it get there? I don't really know, but I do know that certain patients with certain mutations are more likely to develop brain mets and may be more likely to develop leptomeningeal disease. Kind of as a hopeful / scary statement, breast cancer is another a great example of this. Patients with a mutation in a gene called HER2 or in a protein called HER2 are much more likely, almost twice as likely to develop brain mets, and probably that much, again, as likely to develop leptomeningeal disease from their breast cancer over the course of their disease. Why this happens isn't clear. Clearly, it's got something to do with a mutational driver, but I don't quite understand the mechanism. So that's the scary part. The exciting part is we know that we can give HER2-targeted therapy into the CSF. We can give it in that Ommaya reservoir I mentioned earlier, and median survival with that is 12 months, not 6 weeks, 12 months. Half of people are still alive. You can also give another HER2-targeted therapy called Perjeta, or pertuzumab, and that may be synergistic. I don't know. That study hasn't come out yet, but it's in process. And then the last thing is we've got a big drug on the market now called Enhertu, which just dominated the headlines in breast cancer all of last year, will continue to dominate it this year. And that is a targeted therapy that somehow seems to be able, even though it doesn't get into the brain very well, it seems to be able to reduce the size of brain metastasis, and it may delay progression in patients with brain mets, and it may also prevent brain mets for a time. We're waiting to see the final data set on that. So again, I said breast cancer again, but that's because that's how we know the marker. You find HER2 positive tumors in esophageal, gastric carcinomas. You find it in colorectal carcinomas. Admittedly, not very often. You find it in lung cancers. And I think, for me, I don't care if it came from the breast. If you have a HER2 marker and it's in your brain, I'm going to try trastuzumab and HER2. I may try Perjeta. I may try tucatinib. There's a whole host of drugs targeting this. And I think that's something that all of cancer is trending towards. We're becoming individualized medicine for the genetic markers of an individual's tumor. And one day it may not matter where it started. It might just matter what does the DNA test show,
Yeah.
Yeah.
Anyway,
that's where I am now.
Okay.
But I'm in a whole different perspective
Well, I
from
appreciate
most
that.
docs. Yeah.
Dr. Wallace, I appreciate your time today. This has been very informative talking about leptomeningeal disease. I feel much better educated. I hope those watching or listening to this episode also feel empowered, because knowledge really is power, and that's what we try to do here. So thank you for coming on today.
Thanks for having me, Chris. It's been a pleasure.
And you're welcome back anytime that you have a topic you want to share.
Ooh,
the door's
careful.
always open. So
It's a dangerous offer.
no, it's our job to educate people and inform people. So so we appreciate the work that you do.
Thank you so much. It's been great.
For the rest of you, thank you for watching or listening, whether you are on YouTube or Apple Podcast, Spotify, Google Podcast, Amazon Music. You can find us on a number of services. Just search A Cancer Conversation or Georgia Cancer Center and follow. Give us some reviews, rate us. If you have questions, you can email those cancer@augusta.edu, and we will certainly get those questions answered for you. So we'll see you next time.